Hello, everyone. Hope everyone's having a good day. My name is Omera Taylor. I'm joined here by my colleague, Rodrigo. We're from HealthWorks Studio, and we're here to talk to you about AI in healthcare and building healthcare companies. So we're really looking forward to this conversation. Particularly what we're looking to do is to talk to you first about the art and science of building healthcare companies from scratch. The glories of that. And then I'm going to pass you over to my colleague, Rodrigo. He's going to speak to you specifically about AI in healthcare, and then also bringing that all together, understanding the challenges and opportunities of building AI companies in healthcare. Our goal is to have this be a tight 30 minutes, if you will, because we're really interested in talking to you and answering your questions. Specifically, we like to be conversational. So please, as we're talking, please enter your questions into the chat. I am sharing from presenter mode, so I may or may not see them. So I'll ask Ro to flag if there are additional questions that we have, and I will do the time-honored tradition on a webinar of wandering around and looking for that question. You also can ask questions at the end, but please, we are particularly interested in hearing from you and making this useful and a good use of your time. Ro, anything to add before I kind of hop into it?
No, again, thanks for having us here. We're super excited, and yeah, ask questions, talk to us. This is a casual conversation, so we're looking forward to chatting with everybody.
Yeah, yes, thank you so much for having us. All right, so to start, I'm just going to set the stage to explain who are we and why are we talking to you. So we are associated with HealthWorks, which is a brand you may or may not know. We are a spin out from Care First, so that's Blue Cross Blue Shield Mid-Atlantic. And the idea is that we are a three-pronged venture approach to tackling healthcare problems. We have a venture studio, an accelerator, and a venture fund. And because we're payer-backed, when we talk about healthcare problems, we're really talking about total cost of care. Now, as you all probably are very familiar with, this is very relevant because healthcare is incredibly expensive in the US. It is $4.3 trillion annually. That is 12 zeros. That is a tremendous amount of money. It's roughly a fifth of our GDP. And this would be a problem in a vacuum, but it is particularly a problem because we pay roughly twice as much for healthcare for worse healthcare outcomes than comparable countries. So put simply, there's a whole lot of problems to solve. Specifically for Ro and myself, we work at the HealthWorks Studio. So that is a venture studio. For those of you who are not familiar with venture studios, the idea is that you build de novo businesses. So this is businesses from scratch to solve unaddressed market needs. So this really functionally means that what we do is we deeply understand a problem, the stakeholder incentives, the system incentives, and then we identify a solution, we build that solution, pilot, test that, and then launch it into the market. So we really enjoy our job. We're functional problem solvers. The focus of this presentation is really more on AI and healthcare and building companies. So we couldn't shoehorn in seniors, but they are in fact, seniors and aging is a huge focus of the studio itself. One of our portfolio companies is called Perch Houses. So that is a solution that is co-living, shared living for senior women to allow them to age in community. So that's a company that's out there in the world. Other areas of opportunity that we've also explored include caregiving, senior loneliness, looking at hearing aids, and also senior sexual health. So really looking at a whole lot of problems in the world. Now, of course, there are other people who are solving problems in healthcare, particularly like seed, pre-seed stage companies, and those folks can get involved with our HealthWorks Accelerator, which you also may know as 1501 Health. So that is a year-long program that's funded with a larger cohort through payers. And then finally, for those Series A, Series B companies that are really out there, have traction, are growing in the market, we also have a venture fund. And they do direct fund investments, fund-to-fund investments, and then directly into companies. So that's a little more context about who we are and why we're talking to you. I'm assuming there are no questions. Let me pause. Any questions as I tee that up? Are we seeing anything in the chat? Fabulous. I'll pretend that's because I explained it very well. So when we double click on the studio specifically, the question is, okay, so what do Ro and I do? And really, essentially what you do when you build a company from scratch is you have to deeply understand a problem. And the way that we do that is we use a DVFI framework. So we think about the desirability, the viability, the feasibility, and the impact of a problem. And this is useful for you all and also will contextualize some of the conversation that you'll have with Ro about AI, because this helps you deeply understand, am I solving a big problem? Will someone pay for it? Can I build it? And what is the healthcare impact? Specifically, when we talk about desirability, it's exactly what you see on the screen. We want to understand that there is a big problem that we're solving, right? So when we talk about problems, talk about Black maternal mortality, we talk about teen behavioral health, elder loneliness. So there's a huge dollar amount underpinning it, and who cares about it? And if you were to solve it, would it be a nice to have or a need to have? Traditionally at the studio, we like to look at problems that affect roughly 1% of total cost of care. So that would be $4.3 billion at a minimum. For viability, once you know you have a big problem, the question is, okay, will anyone pay to solve it? So you have to understand your buyers and your key stakeholders in order to address someone who not only has a willingness to pay, but they have a willingness to pay that is substantial enough that you can not only build a business, meaning will people pay you more money than it costs to run the business, but particularly there's a question of, can you create a venture backable business? And when we say venture backable, we essentially mean the growth and scaling of the organization. So you know that like classic J curve, right? You'll see frequently that year on year growth that venture capitalists will be expecting a triple, double in terms of the kind of growth in healthcare. I'm a proponent of double, because it takes a little bit to start to grow. I will pause and see that we have this. All right. So to quickly answer your question, for studio, accelerators, etc., startup founders do not need to be affiliated with Johns Hopkins. Again, the way that we handle founders at the studio is that we identify the problem ourselves and then we hire founders on top there, but we don't need to have any affiliation. Thanks for that question. So again, once we understand there's a big problem and we believe there are people who would pay to solve it, which I cannot overemphasize as being important. The question is, can you build a solution? This really is where Rodrigo shines, because he gets to be the director of engineering and say, it turns out this is pretty expensive and hard to build, or yes, we can do that. And so that is the crucial thing, which is your time and resource constraints, right? Because there are many things you can build. The question is, can you do them in a reasonable time? If you have a startup, will you run out of money before you have to build them? And then will people actually use this thing? And are you investing in the most important value driver in your business? This is a huge component of feasibility. And then finally, we have impact, which is that we're a healthcare studio, right? So we want to make sure that we're building solutions that have appreciable impact on health and healthcare costs. And appreciable means measurable. So you have to think deeply about, what am I building? What is the impact that is going to have on care? Now, let me pause here. Did we have additional questions? Ooh. Well, that feature just went away on my Zoom, so I'm just going to let it roll. Unless anybody's going to chime in on Ro.
You're good with questions.
Okay, bad. So now that you understand how we like to kind of tackle and understand problems and solutions, I want to double click on stakeholder incentives, because if there were one thing besides DBFI that I could shout from the rooftops, it would be around deeply understanding stakeholders and what they care about, and crucially, what they make money from and what they get penalized from not doing successfully. Now, healthcare obviously has infinite number of stakeholders. The 6 that you see on the screen here are kind of the big dogs in terms of the ones that the studio thinks deeply about. So I'm just going to focus specifically on them for these purposes. The idea here for payers is, when I say payer, I mean any risk-bearing entity. So this could be a commercial payer, it could be Medicare, it could be a managed care organization, right? The idea here is the number one thing that they care about is reducing cost of care. It's the simplest and like the most important North Star for payers, that if they have a problem that is costing them money and solving it will save them money, then they really care about that. Secondarily, they do care about member experience and satisfaction. This is more of a function of market forces, which they know they're in competition with other payers. But I would say that it is far below their focus on reducing cost of care. When you move over to the 2 stakeholders on the right here with providers, the reason there's this delineation is between fee-for-service and value-based care. Essentially, what is the payment mechanism and what are the incentives underpinning it? So providers for fee-for-service, they care about volume-based payments, right? So it's the number of interactions is going to make them more money. Their number one concern is revenue. If we're going to make a blanket statement, this obviously is incredibly simplistic. Revenue, we are a capitalist society, so they're trying to increase their revenue. And then the second thing that providers, or you can talk about hospitals, right? This is a kind of inelegant or at least reductive bucket, but this could be providers, hospital systems, clinics, care about is autonomy in medical practice, right? This is incredibly important. We see this in venture as there's been a movement towards private equity, the idea that you're seeing a lot of chafing from providers themselves because they feel like they have less autonomy in their practice. That is important to them, and they will pay to maintain that. The other providers you see here are value-based care folks. So similarly, they're also hospitals, the individual physicians and providers. Their payment structure, because it's a capitated model, means that essentially payers and risk-bearing entities are trying to incentivize behavior in which they're thinking about the cost of the care relative to the quality of the outcome. So this means these stakeholders care, of course, about maximizing their revenue, which now is a function of the quality of the care that they are providing and also the cost of the care they are providing. And they too care about this autonomy in medical practices. Now, of course, patients are incredibly important. This, when I say stakeholder incentives, I'm using a buyer framework. I will say the studio typically builds more B2B than direct to consumers. We do perk houses, which I mentioned earlier, that's direct to consumer. Payers, patients care a lot about, of course, quality of life and healthcare outcomes. This is something that's incredibly important to them. Cannot overemphasize the importance of cost. A lot of healthcare is out of reach for a lot of individuals in the US healthcare system because they simply can't afford to pay for it. And then finally, you don't want to overlook the importance of autonomy in a medical system that is not set up for you. So it is incredibly important for patients to feel like they have control over their decision making. And then finally, before I see there's some questions in the chat, we look at employers a lot. I have a delineation between employers and self-insured employers. For some folks on the line, this may be completely standard. For other folks who are like, I have no idea what that means. To avoid going down a rabbit hole of talking about risk-bearing entities and sharing in the context of employers, I'm going to try to keep it simple for you. So for the first employer box that you see, these are your traditional employers. As folks on the line may know, their first cost to all employers is salaries. The second, health insurance costs. Premiums are incredibly expensive. So employers care about reducing those costs because that is a huge line item on their P&L. Secondarily, they care about employee productivity because that's how they make their money. And then also third, employee satisfaction. This has to do with their retention of talent especially when there's market competition. And also for a lot of folks, they have an HR line. And if they're getting called a whole lot about healthcare, that winds up being a drain on them. And then finally, when you look at self-insured employers, to kind of put it simply, there's been a recent trend in the market really over the past decade where larger employers realize that it is actually more affordable for them to take on their own financial risk for health insurance, which means that they're essentially, you can think of them as a hybrid between payers and employers, because essentially they're collecting the premiums and assuming the financial risk for the administration of healthcare. So reasonably, their incentives are an alignment between payers and employers, which means that they care about reducing that cost of care because they are supporting the premium, and then productivity and satisfaction of their employees. We thought that it was worth spending a little time talking about this because this will kind of contextualize as Ro talks about what are the solutions that people build that leverage AI in healthcare and who are the buyers. And these are 6 potential buyers and the things that they care about. And it's particularly relevant for the nice to have versus need to have, because frequently it's easy to identify. We know that payers care about a whole lot of things. But crucially, you have to understand, is this one of the top 3 things that hits their bottom line? And am I going to solve their problem? And would they therefore be willing to pay for it? Seeing lots of questions. Ooh.
I know.
Woo, we love to see it. Okay.
Yeah.
So not going to share the average check size. Sorry, we got to keep some industry secrets. But I will say that this actually, Ro will actually be able to touch on this because I think this is a big part of how we use AI and who effectively can do what sort of research and then application of AI in order to build a business that doesn't just completely run in the black. I mean, in the red, forgive me. Ro, would you agree that you're going to touch on this a bit in terms of kind of cost?
Yes, yeah. We will. We'll discuss it later in the slides.
Fabulous. So regulators and policy stakeholders are definitely important. The thing that is challenging is, are they a buyer? So this is an incredibly relevant question in healthcare, which is that I think of regulate, and again, our job is to build for-profit companies. So this is a necessarily narrow scope. I would say that regulators and policy stakeholders are incredibly important in the ecosystem, particularly because they can intervene or not intervene and impede movement. We look at CMS a whole lot in terms of what are their pushes in terms of reimbursement models in healthcare that could lead to more opportunities. Or there really has been a restriction. If you look at Medicare Advantage in terms of social benefits, there was a heyday where there were very big check sizes. Now they're reeling it in. That is incredibly relevant for the business models that you can build. I would say for the purposes of this slide, we don't have them because they rarely are the purchasers of solutions, although in the context of AI, you could probably facilitate some streamlining, shall we say, of their operations. The question is, do they have the budget in order to purchase a solution like that? And does it solve one of their top 3 problems? Yeah. Oh, well, thank you. We love a slide compliment. Yeah. And again, this is necessarily reductive because it is helpful to just think, am I addressing some of the top concerns for these individuals? And that finally, in terms of the settings, I'm realizing that I'm not reading the questions, I'm just responding to them. This question is, what setting are you looking for decreasing cost? Home, hospital, skilled nursing facility, assisted living? And the good and bad news for us is all of the above. I would say that the arenas in which we're looking to decrease costs are really a function of 2 main things, which is how big is that cost bucket? What is the extent to which you can influence it, right? Which is it an aggregated amount of cost where one buyer could be motivated? And from a scalability question, would you be able to then scale effectively without having to change your baseline product or solution dramatically? And the second part is sales timeline, functionally. We are a 3-year fund. And so something that we have always wrestled with is especially fixed sales cycles. So this could be challenging with Medicare Advantage on our side. We need to know that we have enough time to be able to pilot a solution with them and then get them to be a buyer. We're technically a 10-year fund in full aggregate. But that would kind of incentivize us more towards fast moving solutions. And in the question of decreasing costs at home, I would overlay this stakeholder map with that, which would be costs for whom? Is it for the individual? Is it for the caregiver? Is it for the payer? Payers are going to have the most dollars per my first point, right? And then hospitals, SNFs, and assisted living. Similarly, as you all very well know, 55% of healthcare costs come from folks over the age of 50. So aging in place and being thoughtful about how we reduce costs and improve quality and outcomes for seniors is a very rich environment to solution in, frankly, because there's just a lot of dollars moving around. All right. Top problems to solve from our viewpoint. Row. What do we want to get on? Here, do you want to try to stuff? I've been talking a lot. Do you want to answer a top problem and then I'll kind of I'll come back?
Where do we start with the top problems? So, I mean, we've addressed the issue of decreasing costs for patient employers and payers as well. One of the things that we see, at least from the technology side in healthcare, is the ability to consume large amounts of data and have actionable plans from it, right? We're able to consume all this claims information, patient information, et cetera. How are we able to turn this information into something that's actionable and can give us results that improve patient care? It's one of the topics that we'll discuss a little bit later in the slides, but from the perspective of technology, that's where we can leverage it the most in order to be able to have better solutions for a lot of our patients or a lot of our customers. So that would be my take on this. Amara's might be a little bit different.
No, I think that there is no wrong answer in terms of top questions. For the purposes of this slide, I think something that is interesting in terms of problems is this bifurcation of stakeholders, which is more employers are becoming self-insured. Who the risk-bearing entities is changing in the landscape, right? There's this push towards managed care organizations. What's happening with Medicare Advantage is changing. There's a push towards DSNP, so dual eligible, depending on the state that you're in. And because of this, the entities that are at financial risk for healthcare outcomes are changing, and they are kind of disaggregating and then aggregating again. There's this interesting inflection point. And so this is less of a top problem, but more of a problem for building solutions, which is when you think about who your buyer is, It's not static. And so the problem that you are solving and for whom has to be like, one, a big problem that you're solving, and two, you have to have a kind of agile and nuanced identification of who your buyer is going to be if you believe that is going to be a continuous problem. I could talk about this all day, but I will pause that. I was like, oh, another thing to hit. Thank you for your questions. Keep them rolling. And I think I vaguely know how Zoom is working right now. So okay, now, and I'm about to kind of close out my portion, which is just, again, to kind of hammer it home, the key takeaways from my aspect is really the importance of building problem-first solutions. It is very easy, I think, especially when there's technological advancements, especially in AI, to build something cool where you're like, this is so cool. No one has done this before. If you have a solution looking for a problem, it will be very difficult to build a business because you need someone to pay for it. And sometimes you can find people, especially as Ro's going to hit on in terms of where we are in the cycle and the bubble associated with AI. It is very important and it is very defensible to be able to have a problem-led solution. And then finally, again, stakeholders, understand how they make their money, how they lose their money, and then try to build a solution that unlocks untapped value. Particularly if you can see an alignment between stakeholders that other individuals haven't seen, and you can get a win-win or a win-win-win trifecta in terms of each stakeholder, this is really a good way to make yourself defensible and insulated in a changing market. So Ro and I are now very smoothly going to transition to who is sharing their screen. She says aspirationally, so I'm going to stop sharing. Are you ready, Ro?
I'm ready.
Okay.
Go for the handoff.
We did it.
And
nailed it.
Are we good?
We're good. Please.
Oh, perfect. Okay, so let me just fix my windows really quick, and then very professional here. Excellent. So thank you, Mara. So we talked about the stakeholders. We talked about what HealthWorks does. Now we're going to talk about a little about what AI in healthcare means to us, and then also some of the lessons that we have learned as a studio, and where we see a lot of value when we're building AI software, applications, etc. One of the things that AI has promised in healthcare has been a reduction in administrative burdens. It has allowed clinicians to focus on patient care. It allows us to consume a lot more data, like I was mentioning before, to be able to make actionable decisions. AI-driven diagnostics and personalized treatments, which has been, it can lead to better patient outcomes, but as we'll see down the line, it can also lead to some distrust from some of the providers that we work with and some of the providers that you will work with as you build these solutions. And then the reality is that when you're building technology and especially in AI and healthcare, the reality is more complex, right? The journey from a promise to practice involves significant challenges, opportunities that you must navigate carefully. This includes, technical, ethical, and regulatory challenges. So I thought it was a great question earlier when we talk about regulators. Regulators do play a role here, a very important one. So I want to take us back. As we see Doc Brown popping up, I want to go back to the past. I want to go back to the 90s a little bit. The environment that we're in right now is very similar to an environment where back in the late 90s when we saw an internet bubble. If you weren't therefore, the late 90s saw a huge surge of internet-based businesses, and many of them were superficial wrappers around existing processes. We had companies like pets.com and Webvan. Pets.com failing due to an unsustainable business model, the inability to attract loyal customers. Even though the ideas were great, their plans wasn't fleshed out. Webvan, believe it or not, was doing grocery delivery service back in the late 90s. Now we have Instacart, right? So it's crazy to think that didn't work out for them. But they faced logistical challenges and financial challenges that led to its failure. The reason I want to bring this up is because out of the late 90s, we had a few companies that came out that revolutionized and transformed the way we work with technology today. Amazon revolutionized online shopping with scalable, efficient e-commerce. They focused on customer experience, logistics, tech, integration, and then Google obviously transformed how we interact with the internet as a whole. It's now become a verb. I will now Google something. Incredible for a company to be able to have that effect. But they built a powerful search engine. They with a great algorithmic accuracy and user-centric design. So the reason I'm saying this is because a lot of what we're seeing that happened in the internet boom of the late 90s is mirroring itself now again in the AI boom. We see an AI landscape where many AI applications are becoming superficial, but it has the potential to similarly bring transformative impact in healthcare. This requires us as builders, as innovators, to go beyond superficial applications and focus on value-added solutions. Any questions? I'll pause there. I feel like I'm trying to read. Would development and support of workforce capacity, clinical practice skills be part of the administrative bucket or the latter bucket? Yes. I think when we're dealing with anything that's going to allow our clinicians, our administrative support to work and our workforce to increase capacity and efficiency, we look at it as the administrative bucket of AI, right? Things that are going to make the daily life of providers, payers, health plans easier. So yes, I would put that in the administrative bucket. I think this question might be more for you, Omar, how to get buy-in from the patients, especially seniors. Let me throw that to you because I feel like that's going to be your market a little bit.
Yeah, sure. I mean, I don't think I'm going to say anything that people on this call don't know, which is I think buy-in, I think there is the, are you solving their problems, right? The thing that's challenging in the healthcare landscape is often your buyer is not your user, right? So you get to have a fun nesting doll of all these stakeholders who incentives and needs you have to address. And you can't address, it's an order of operations in my mind, right? Which is that if you're addressing just the user's need, but not the buyer's need, you won't be able to get off the ground because you won't have any money. If you just address the buyer's needs, you'll get as far as being able to get the money to build the thing, and then you're going to try to have someone use it. I'm sure that Ro could tell you about some battle scars from this experience and try to get users to engage with it, and then you fall down flat. The big thing about seniors is that you'll see there's some studies that say that there's low tech literacy, there's some that say they're high. I think it really is a question of who are not only the stakeholders as the patients or the seniors themselves, but also their caregivers, their enablers around them, and what is the value that you're driving for them in the collective that would incentivize them to engage with that solution. And I think people are not a monolith. You got to talk to them. You'll have lots of assumptions about how they're going to engage in things. And then when you actually put it in front of them, you'll figure out that they're going to use it in a totally different way. So test early, test often, and be willing to be unprecious with your preconceived notions.
Absolutely. I mean, and to build on that, don't forget that the solutions that you're building are, they're not just solutions. For a lot of our users are livelihoods. So if we're talking about solutions for seniors with like dementia and Alzheimer's, there's a lot of technological advancements that we see could grow there. And even though you might not have, like Omar was saying, the technological literacy, the caregivers do, right? And this is who you're trying to appeal to. A lot of the caregivers are in need of a lot of assistance and new technologies to allow them to give care more efficiently and better. So that's who you would be targeting directly as well. What is unique of your studio out of other incubators, accelerators, and VCs? Oh, I feel like they're targeting you, Omar, with all these questions.
I'll give you the quick and dirty is I think our relationship with payers is we uniquely understand the reimbursement landscape. We have a direct relationship with CareFirst and other blues in the ecosystem. This is important because health insurance companies cover almost every dollar and touch almost every dollar in the healthcare system. So that unique understanding of reimbursement, you even saw it in my stakeholder slide, allows us to really cut to the heart of who pays for what and why.
Yeah, and I will say, I think this also ties into Mark's question about how hands-on our team is with engineer support. So I'll kind of answer both. I think the big advantage here in our studio is that we're able to have a team that is well-versed and multifaceted. We're able to provide support in, the product creation, the marketing, engineering. We have the connections, like Amar was saying, with payers that are able to leverage their contacts to be able to get our founders a larger reach. So we think that as we walk with our founders through every phase, we try to give as much support as we can, because in our minds, the only thing that we're looking for is for their success. So we're always available, we're always reachable. We have a fantastic team of professionals that work day in and day out. And, we really do pride ourselves in the support that we try to give our founders. There's no more questions. I will go to the next one. I really wanted to highlight this slide. I think this is an important one that I want to drill to a lot of entrepreneurs and founders out there. The lessons of what we just discussed about these companies that failed, right? Every great failure has a great success. When we look at how Webvan failed, we looked at the importance of operational efficiency and sustainable growth. You have to focus on creating sustainable business practices that emphasize operational efficiency and cost effectiveness. This goes back to that question earlier. We talked about training models and how much the check size is for training data. We do know that training data is expensive. There's obviously a lot of programs out there, like with AWS, for credits to be able to help you train some of these models. The important thing is that you always keep in mind that as you're building a startup, you maintain that cost effectiveness and try to be as efficient as possible. You don't need to deliver the full product day one, right? MVP. You can gradually scale out, and as the solution grows, you can invest more and more into growing it, right? So you need to. This drives into that second point of you need to understand your market demand, and then out of that you need to build your loyal customer base. So if you're building a healthcare solution, make sure you understand your market research. Make sure you do market research. You start market. You understand the specific needs of healthcare providers and patients, and then develop solutions that address these needs effectively. I know that I keep saying effectively, efficiently. These are really the buzzwords that we want to make sure come across, because we've seen in our own businesses that those are really the adjectives that make sure those companies are successful. Finally, the last two things I want to talk about is, what made Amazon and Google successful: scalability and technology integration. Invest in technology infrastructure that supports scalability integration. Focus on creating a user-friendly experience for both patients and healthcare providers. I cannot emphasize how important it is that patients and healthcare providers have a user-friendly experience. Providers in general are not going to be your tech gurus, and so for them, their days are incredibly busy. They are overworked. They're stretched incredibly thin. Anything that makes their life easier, it will be easy for them to adopt. If they need to learn a new system, if they need to integrate with a new EMR and there's complications, they will drop you immediately. They do not have time for it. And so just make sure that things that you're building, you always take the user into consideration. And the last thing, innovate in core technology, right? That can lead to transformative impact. So prioritize continuous innovation and improvement of your core AI technologies. And this doesn't just apply to AI, right? Your business technologies. And then ensure that all the data that you're using for both to train AI models or just to make insights and decisions is accurate and representative of diverse populations. So one of the complications that you'll find in healthcare is data is not great, it's ugly, and it's incredibly difficult to work with sometimes. So just make sure that the data that you have is accurate and representative, and that your models are tested correctly, not just for AI, but for any business technology that you're using. I'll pause there, see if you have any questions. I think we have two.
We have a couple. I guess my question for you, Rose, for the ones that are more studio focused, do we want to hold those until the end so we can be focusing on AI specifically, so kind of so we don't have to hop in and out, or are you okay hopping in and out?
Yeah, I mean, if you want, we can. I'll finish mine. I'm almost done with my side, and then we'll talk about more of the studio, and then we'll just go do the back and forth. I like the opening QA, so I think that's better.
And then, of course, if people have questions about specifically what Rose is saying, chime in and he can answer.
Yeah.
But we won't forget you.
Yes, so we'll come back to some of those, and then we'll be wrapping up this little tech one now. So I want to just mention a couple of misconceptions about AI. I know Mara mentioned a little bit about the landscape and how things might be changing a little bit now. There is a bit of AI fatigue, we feel like, right? I think some of the statistics we're looking at is saying that 85% of AI startups will be out of business in 3 years. So there is a bit of fatigue we're seeing here from Y Combinator, from other VCs in the market. So one of the things that we want to make sure is that we don't keep feeding into that bubble and into that fatigue by getting rid of some misconceptions, right? AI will not replace doctors in the near future. I can't say where we'll be in 20 years, but we think in the near future that will not happen, right? We do have the ability for AI to augment human capabilities. It's able to enhance decision-making, support healthcare professionals, but not replace them. We feel like a lot of the emotional touch and the human oversight is still going to be necessary. There has been some studies of even some false positives that we've looked at through AI, where we had chest x-rays giving false positives with AI tools between 13% and 30%, where radiologists were only about 11%. So we're still seeing the doctors are a crucial part of that. They won't be going anywhere anytime soon. They have empathy and they understand patient care. So we feel like when you're building AI tools, it's to support the doctors. Don't be looking to replace them. I don't think that that's going to be where we're headed yet. The other side of it is, and this is a big one, AI is not a magic bullet. right? It's not a one-size-fits-all solution. It requires careful integration into existing workflows, EMRs, EHRs, and systems to effectively deliver and deliver real benefits. Effective AI implementation demands tailored approaches to specific problems. So consider the unique needs and constraints of each healthcare environment you're working with when you're building these solutions. I think we're good. Okay. So how do we build value-added applications? They go beyond simple automation data analysis, right? They address real pain points in the healthcare system. Some of the examples that we were drawing up just for this presentation were personalized treatment plans. You can analyze vast amounts of data to tailor treatments for individual patients, improve outcomes, and reduce trial and error prescribing. It's a big concern that we've worked with. We've done analytics on it as well. And so allowing us to give personalized treatments to patients, predictive analytics, being able to predict disease outbreaks and patient needs, allowing for proactive care, early interventions, that leads to better patient outcomes and efficient use of healthcare resources. That is a big one. There's a lot of waste in healthcare. It's one of the things that our studio has been discussing as well. How do we reduce waste? And so the value-added applications that we look at are things that are going to make the day-to-day for providers easier. Clinical decision-making, right? Which is recommending timely insights, enhancing patient care. And there's been some studies that have also shown that AI can significantly enhance clinical decision-making by providing timely insights and recommendations based on large amounts of data sets, right? And that is, I think, where the power is, being able to analyze claims information, patient profiles, et cetera, being able to provide some clinical decision-making that maybe a provider wouldn't see on their own. So based on that, what are the challenges that we see? This is a very similar slide talking about the stakeholders. These are the stakeholders when developing AI solutions, right? The challenges you face. Number one, and always number one in my book, is data quality, right? High quality is crucial for effective applications. Poor data quality is going to lead to inaccurate predictions, suboptimal outcomes, distrust. And so when you're integrating AI solutions with existing healthcare systems, it can be complex and requires careful planning and execution. So make sure that when you're integrating with EMRs, EHRs, you understand the systems, you understand the complexities, and you understand the data that you're getting. There's also the regulatory compliance, right? The big one there is navigating the regulatory landscape nowadays. It's essential. Regulations are still updating as AI is starting to come into healthcare. As we all know, healthcare is very privacy focused with HIPAA. And so we see things with patient privacy where protecting sensitive data is paramount. There was recently a big leak. So as we all know, that happens. Make sure that's not you that's happening too. The last few that I want to talk about is, and then we'll kind of group this together, is scalability and interoperability. So design solutions that can scale efficiently and meet growing healthcare demands, and also ensure that your systems can work seamlessly with a variety of healthcare technologies and standards. There are multiple systems. Your providers, payers, et cetera, will have multiple systems that they work with. You have to be open-ended, be able to be interoperable with both FHIR, HL7, whatever data they're using, whatever integrations they have. You have to be able to pivot and work, because a lot of those payers, providers are not going to leave the systems they currently have for yours. The last couple of risks I want to talk about here is, and these are for the algorithms themselves that we see, is bias. We see systems that can inadvertently perpetrate and exacerbate biases present in training data, right? This can lead to unequal treatment and outcomes for different patient groups. We have an over-reliance on AI, and we can already see that nowadays in other markets, not just healthcare, where there's just a risk that healthcare providers will become over-reliant on AI and potentially overlooking their own clinical judgment and expertise. And so lastly, the data privacy. Again, I want to highlight this one more time because this is a big one. Just ensure that your patient data is securely stored and managed. Critical breaches or misuse of data can have severe consequences for patient trust and safety. These are I think, the three biggest risks that we're seeing currently when it comes to building applications in the healthcare market. Last slide here that I want to talk about, second last slide, I believe, is opportunities. we wanted to make a list of just some kind of ideas that we throw around in the studio of some venture-backable AI businesses. And those include, telemedicine for remote patient care and monitoring, AI-driven diagnostics that improves accuracy and the speed of diagnosis, leading to better patient outcomes, more efficient healthcare. AI-powered virtual assistants, which have, we already see them in some plans that they handle routine inquiries, they do appointment scheduling, follow-ups, improve patient experience, reduce the workflow, predictive healthcare as well, AI that predicts disease outbreaks, we mentioned this before, personalized medicine. This one's great. You can analyze genetic, lifestyle, and clinical data to create personalized treatment plans. So these are just some of the ideas that we've been kicking around the studio, some of the solutions that we're wanted to give you guys some food for thought.
Yeah, and if I could chime in briefly, if we tie this to the problems that they solve, right? You could overlay this, maybe you're doing the exercise in your mind, right? Which is that if you think about telemedicine or, for example, AI-powered virtual assistants, so the questions of, we know there's a huge supply constraint on providers. So how can AI supercharge existing providers to address the fact that there are too little and there's a huge problem with burnout, for example? So this is how you would kind of anchor it to who's the problem, and then you'd say, who cares about the fact that there's not enough supply of doctors, for example? So the patients obviously care, have to wait a whole lot of time. Payers care because people are getting worse when they have to wait longer to get care, right? And then the providers and hospital systems care, of course, because they are unable to make as much money. They also have their workforce is burning out. So this is the kind of overlay of how you think contextualize the problem here. You could extend to personalized medicine and AI-driven diagnostics if you believe there's a huge delta between the outcomes and diagnostics that are currently existing, which are allowing people to go untreated or get sicker for longer, which makes their care more expensive. So this is all how you kind of stack and marry problem context. What would your solution be, and who are the stakeholders who care about it and why?
Yeah, and I think the important thing there is that it's all about supercharging the provider, right? Being able to, like I've said, they're spread thin. They are incredibly busy. So anything that can make their life and business easier, and the idea that they can give better care for their patients is going to be a win in our book. The last slide I wanted to leave everybody with is, I think, very valuable. This is basically our logic of how to build venture-backable businesses, right? Not just AI businesses, but what do we look at? We look at identifying real pain points, focus on solving genuine problems in healthcare. And this involves understanding the challenges faced by healthcare providers, patients, payers, etc., right? Take all the stakeholders that Amara was mentioning before and really think about what are their real pain points. Build human-centered design. If you're building AI solutions, make sure that the end user is in mind, right? Engage with the healthcare professionals to understand their needs and workflows, understand their day-to-day, understand their integrations, what systems they work with. Leverage high-quality data. This is a big one. If you're able to get high-quality data and you have access to it, it's the foundation of effective applications, not just AI solutions, but any business applications for healthcare. Ensure that you have robust data collection, management, and processing. Integrate with existing systems. This is a big one. Again, seamless integrate with EMRs, EHRs, existing systems in healthcare, and enhance usability and adoption, right? Anything that you can do to improve a provider's day, payers, workflow, etc. Ensure that you have regulatory compliance. We discussed this. Focus on scalability. Again, design solutions that can scale efficiently to meet the growing needs. Demonstrate value. Clearly demonstrate the value of the business, right? Through pilot projects, case studies, show tangible improvements in outcomes, efficiency, and cost savings. And then lastly, you will all secure funding, right? When you are presenting a compelling business case to potential investors and you highlight the market opportunity, the competitive advantage, and the return on investment, that makes you a very attractive business. It'll make you an attractive business for anybody. So to me, these, when we're discussing with Mara, these are the key points take away of, if you're going to build an effective business in healthcare, these are the things that you should be looking for. And any questions? I guess, Amara, if you want to answer the more studio focused ones with
Yeah, Sure. So I can kick that. Also, if you have more questions, please add them to the chat.
Yeah.
You know, we love talking about this stuff. In terms of which payers our studio is connecting with, so I would say obviously we're affiliated with Care First. So Blue Cross Blue Shield is a kind of our home court, if you will. So that's both Care First and the larger associates of all 32 across the U.S. In terms of Medicare and Medicaid, I would say that in the context of Medicare Advantage and Medicaid, that is within the Blues. So we also have conversations with folks per the Humana point. Other payers, I would say our closest relationship with the Blues, but certainly not our only relationship. If you want to scale effectively, you have to scale to lots of payers. So it cannot just be Blue Cross Blue Shield, as beloved as they are to us. And then the question of like employer, so we're looking both at self-insured and risk accounts. So we understand that there are different stakeholders there, also talking to brokers. We have a variety of relationships with a number of payers. So really no one's at the no one is off limits, if you will. Let's see. Are we interested in startups designed for acquisition from the get-go? Would CareFirst be willing to acquire the companies that create value, reduce costs, improve outcomes for their core business of covering patient lives?
Good question.
A good question. Look, you might answer, and then Bro can tell me if it passes the sniff test. I have to say, no one's asked a question yet where we've had an all-out debate, because we do have different opinions on some things. So, so I would say HealthWorks as an entity is an interesting question, right? So as the studio, the idea that is more challenging in terms of designed for acquisition, to your point, it's acquisition by whom? I think if you're going to be acquired, certainly CareFirst has acquired companies in the past. That's more through the corporate development arm. That is a really predicated on there being a body of evidence in terms of the traction that that solution has. So acquisition is not going to occur unless it's clear that you have a long track record of driving values. Per your point, the creating value, reducing costs, and improving outcomes, absolutely. There's also lots of opportunities to be a vendor, right? Or to partner with CareFirst in other capacities. So I would say that there is an avenue for acquisition. I think it is smaller and it's predicated on you having been around for a while. But if you're part of the HealthWorks and CareFirst ecosystem, mostly studio, as we said, as Ro and I said, we come up with the ideas and then kind of land the founders on top of it. So that would be the earliest stage. And then for seed stage would be your accelerator, and then Series A, Series B in terms of investment and fostering a closer relationship with potential buyer and pilot opportunities with payers. That would be our venture fund. Ro, anything you'd add there?
That was, yeah, absolutely. That was perfect. I think just to sum it up a little bit, we're not an acquisition first studio, but obviously some of our companies do end up in the acquisition phase. But again, like Amara said, we are, as far as reducing costs and improve outcomes, we love that.
Yeah. Exactly. And all money is good money. So acquisition is not a bad way to go. It's about when and for what dollar price.
Exactly. Would you share some insights on how startups leverage high-quality data without access to any EMR, payer, or hospital data? Absolutely. We actually just had to do some of this. So one of the great things that you can do is you can go on the CMS, CDC, or like the WHO website, and you can actually have public health data. You could use SDOH data. You could use synthetic data from CMS. So you will be able to get access to outpatient claims, inpatient claims, member reports, membership rosters, et cetera, all for Medicare and Medicaid plans. So if you're looking for a place to start, that is the place that I would recommend.
Yeah, and the only thing that I would add from my like knowing way less, but 2 cents, is that like her just really underscoring Ro's earlier point about data quality is that it's always good to have good data for testing and kind of trying to figure out if something is solved. What matters the most is how representative that is of the ecosystem you are now going to have to connect to, and the data you will be receiving and have to like synthesize, analyze, and then spit back out. So certainly looking and understanding to what extent is this representative of other entities that I will be engaging with, because sometimes you can build something that is beautiful and then you wander into the real world and it turns out that no one is formatting their data like that, or they just like the idea of FHIR and no one's doing it, which I'm sure all of Ro can speak to with much more detail.
Yes,
but that's what you have to check.
Very much so. And the last thing I would say is don't be shy of asking. Reach out to an EMR, reach out to a payer and ask them if they have synthetic data, ask them if you're willing to get access to it. A lot of payers and a lot of EMRs do have sample data that they can send out. They just don't make it public. So if you're able to reach out to them, I'm a big fan of asking first and then seeing what happens. The worst they can say is no.
Well, that's well put.
Yeah. Any other questions?
Yeah, it seems like we're at the end, but if there are any other questions about studios, how we think about businesses, how you think about applying some of the research that you all are doing, unfortunately, we cannot see your faces, so we do not know what your background is. So we have to kind of spitballing in terms of what your interests may be. But we'll give you, I know it takes a little bit to type a question, so we'll give you like, I don't know, 30 more seconds. Let's see if questions pop up. And I think we'll probably fill it. Oh.
Contact information. Yes.
Yes, we have a, oh my goodness, I'm so sorry. I hope you cannot hear the chorus of dogs barking above me.
Yeah.
Our website is on that first slide. We are healthworks.studio, and you can contact us through our website there.
Yeah, feel free to reach out to us with questions.
Yeah, please. We're happy to answer them. And Ro, speaking of which, we have another question for you.
Do you see the applications required to integrate with EMR? So good question. I think it depends on what you're trying to solve. If you're building a analytic system for a payer that's going to have to work with, claims and update records, et cetera, then yes, you're going to need an EMR integration. Luckily, there's a lot of companies out there that do have EMR integrations that are very easy to integrate for you. You can look at things like Redox, Health, they have great EMRs, OptumRx. The vast majority of what we've seen, and Amara, let me know if I'm off base, is not really. A lot of the applications we're seeing today is for the day-to-day of a provider, right? To remove the administrative workflow. That's where we see the biggest focus of how do we remove the paperwork, how are we able to streamline the patient outcome, the process, the onboarding, et cetera. We're not seeing so much on the EMR integration side, and that's probably because a lot of the EMRs are not great. And so there's definitely a huge opportunity. And if you're looking to build things that are going to work with claim systems, updating medical records, you're going to have access to that data. By all means, reach out to some of the companies that I said earlier that do have some pretty decent integrations to work with.
Mm-hmm. Yeah, and the only thing that I would add is that when I'm wearing my business designer portfolio director hat, whenever I have a team that comes back and says, okay, it's great, and then we're going to have an EMR integration in our early solution, I always have a kind of clutching your pearls moment where you're like, oh God, that sounds expensive and very time intensive. I think that's something that is unique, particularly about this program and offering at Johns Hopkins, is that if you have the opportunity to do a lot of your learning in a research environment where you are well funded, that will pay dividends for you, because startups are an exacting business and capital efficiency really matters. Depending on the investor that you are engaging with, they either will have context and patience for you to spend a whole lot of time on R&D, right? Or they will not. And so I think something that's happening with AI is that you're seeing a diversity of stakeholders and investors who are varying levels of literate in what it takes in order to build something. So if you have the opportunity to leverage kind of a soft landing pad where you get to learn a lot, try things, fail, and spend the kind of the hours, capacity, and funding in order to really fine tune what you're building, and then you launch more into market where you get to be subject to the less tender missives of capitalism, I would highly encourage you to leverage the expertise of the environment you're with, and also the kind of resources that are available to you.
I will echo that robustly. Yes. And by all means, experiment and create new solutions while you're still in that research environment, and leverage all the contacts and information you get.
Yeah. Ooh, I love this question, so I want to hop on it first. What specialties do you think startups should focus in first? I think you have to look at what's most expensive. So most expensive is, it kind of depends on how you slice and dice it. Specialty pharma is the biggest thing you're going to see from payers, where they care about the things that require most, pharmaceutical intervention. So you're going to see a lot of cancer. Your biggest in terms of cost buckets is cardio, right? So we have cardio, we have cancer, and onc related things. We also have MSK, so musculoskeletal, and then you start going into chronic conditions, right? So you have diabetes. I'm trying to remember the top 5 from a pie chart in my head, but it's going to be basically everything that hits and is the most expensive. The thing that I would caution is that there are, particularly in chronic conditions, there's this seductive feature, right? Where you think, this is a very big bucket. It is very complex. There is no good solution. I'm going to go in here and I'm going to health solve it. The big thing, especially if you're doing anything in the realm of care delivery or understanding diagnostics or treatment, is determining whether or not there is truly a treatment for a condition. Because something, I like to call it comorbidity soup, right, is that when you have a lot of comorbid patients, especially who are older, it is difficult to attribute. You can be like, there's some correlation, Lord knows there's no causation. And so the argument that you're going to make about what your solution is going to make to save money and to focus, you have to have, and this hits the impact of DBFI, you have to have a very discrete understanding of what is the value that you're driving and how are you impacting and how can you be measured relative to it in order to get people to pay you to do that thing. So I would say there are realms in which cardio is very great opportunity because it's very expensive and it's the leading cause of death in the US. And there are areas in which it is difficult because it is hard to affect cardiac health without a lot of patient behavior change, for example. And so being mindful about what problem are you trying to solve and how are you uniquely positioned to solve it is very important.
Mm-hmm.
Bro, anything you'd add or challenge?
No, I agree with you. I would add to that data. I would also add, mental health. I think that's a big one that we're seeing as well. That's being mental health and Alzheimer's and dementia are some of the bigger, I would say, conditions that we're seeing that are more popular with applications that are coming out, right, with solutions. Again, I want to just echo what Amara said. Make sure that the solution you're building, you're not just building a solution to build a solution. Make sure that solution actually solves the problem. And also just because, and I think Amara and I were talking about this before the meeting, just because you're building something that you think is fantastic and great and it's going to solve an issue doesn't mean somebody's going to pay for it.
Yeah. Because it has to be one of their top priorities. Per the point about dementia, I think Alzheimer's dementia is obviously a huge driver of cost. What payers are less familiar with, and caregivers, frankly, because the science just doesn't exist in to varying degrees, or it does exist, but to varying degrees of accuracy, is how you move the needle, right, on it. And so we had an opportunity that we looked at recently around hearing aids, right? Because 48 million Americans need hearing aids. 27 million of them are over the age of 50. There's a really strong association with increased fall, dementia, right? There's a really strong correlation that typically patients will cost up to $22K more a decade than comparable peers. But on average, people wait 7 years from onset of symptoms to getting treatment, and only 1 in 5 people get the treatment they need. Right. So you're like, these are big numbers. This matters, right? This is a whole huge percent of the population. But then when you drill down on it, hearing aids are pretty expensive and you have to replace them every 3 years. Right. And how tightly it's correlated with dementia or Alzheimer's. And like fall risk is a little looser, even though the science does exist, it's not as compelling to those payers. And so we wound up not pursuing this opportunity, frankly, because we couldn't motivate payers to buy and cover a solution that involved hearing aids. So this is like, I encourage you to continue to interrogate.
I think that's about it. Thank you everybody for coming and listening to us. Hope you enjoyed the presentation. If you have questions, you want to reach out to us, we're available. By all means, go through our website. We appreciate your time. Thank you so much.
Yeah, thank you so much for having us and joining us. We really appreciate it.
We really appreciate it. Thank you.
I am fearless.